You know what's quietly sneaky? Your bones. We don't give them a second thought until something breaks. Years ago, I will never forget watching my mother in law, who was in menopause, step out of her car onto my icy driveway, do a little tiny slip, not dramatic, just a little misstep, and shattered a bone in her lower leg. That fracture turned out to be her first red flag for osteoporosis. And since then, she's been battling her bones every day. Here's the scary part. What happened to her is more common than we think. In Canada alone, over 2.3 million people currently live with osteoporosis. At least 1 in 3 women will suffer a fracture from osteoporosis in their lifetime. And here's the kicker, more than 80% of all fractures in people 50 plus are osteoporosis related. But even more alarming as women approach menopause, bone loss accelerates up to 2 to 3% per year in some cases. In fact, during the first 5 to 7 years after menopause, a woman can lose as much as 20% of her bone density. So, yes, bones are important, and far too often we underestimate them until one little slip changes everything. But here's the good news, there's hope, and there's a voice in this space who's turning what feels permanent into something preventable, sometimes even reversible. So let me introduce you to someone who's on a mission to rewrite how we think about bone health, Dr. Doug Lucas. Dr. Doug is a double board certified orthopedic surgeon turned osteoporosis and hormone specialist. He retired, but never really stopped from, you didn't retire, Doug. That's a joke. From orthopedics, so he could dedicate himself to a bold vision, educating the world that osteoporosis isn't inevitable, it's preventable, and oftentimes even reversible. His personal health journey led him deep into the world of functional medicine, biohacking, and a holistic approach to bone strength. He's the author of 2 amazing Amazon bestsellers, The Osteoporosis Breakthrough and Top 10 Reasons Why Your Hormones Are Failing You. You may also know him from his popular YouTube channel, The Dr. Doug Show, Bones, Hormones, and Lifespan. Today, he serves as a VP of Women's Health, Hormone, and Lifestyle Optimization at LifeMD. And yes, he wears many hats, so no, he is not retired. Don't believe that. And leads an international osteoporosis community called the Osteo Collective. He travels the globe spreading his message. Bone and muscle health are the gatekeepers of longevity and health span. So, welcome, Dr. Doug, to the show.
Thank you, Karen. I got to work on the length of that bio. I'm sorry.
I tried to shorten it a little bit, but
Wow.
there was things in there. I was like, I can't not say these things. So, no, you are not retired. I know you, and we've known each other now for a while. And I know you work very, very hard. You're a very busy man.
I am. I am. Yeah, but I have to say that for my orthopedic colleagues to say that I retired from orthopedics. I'm no
Ah.
longer in the operating room.
So I like that you're not like a traditional trained hormone doctor of any sort. So you
Right.
were like full on into bones, and then why did the hormone piece come in?
Out of necessity, more than anything. I mean, I was always interested in them, and so I did, I did the functional training and the A4M stuff, but I had to get deeper and deeper, especially in women's health, because as you kind of mentioned out of the gate, bones are really important. Working on bone metabolism is critical for health span, for longevity, for all these things. And one of the biggest levers we have is optimizing hormones. So if I'm going to do bone health well, I need to be a hormone expert for both women and men.
So you saw that hormones were such a huge part of bone health.
Yeah, it's always in the top three. So people ask me, what's the most important thing I could work on? And for me, I'm always like, nutrition, probably, because if you don't have the building blocks, you can't build bone. Some kind of movement, exercise, impact, whatever you're doing to your body is going to obviously have an impact on your bone, no pun intended. And then the third thing has to be the pressure of hormones, because you can supplement all day long, you can eat all the right food, but without hormones, your body's not going to respond the way you want it to.
Would you say they're the biggest driving factors in bone health?
Um, Boy, there's a lot of factors in bone health. They are definitely one of the biggest for
Okay.
sure. And as we've created programs to help people to reverse osteoporosis, and we're always trying to, trim it down. How can we make it, easier, more simple? And so we really came down to those three things. And so if I had to pick one thing to treat medically, it's going to be hormone optimization.
Wow. Wow. And then once you start diving into the hormones, then it was like, wow,
Oh my
hormones
gosh.
are really important.
And that's why I wrote the book too, because it is such a confusing space. And I love reading
Yes.
research. I'm one of those weird people.
No, I
And
do too.
I would read the research and I would look at how we're treating patients and I thought, but none of this makes sense. Like, why are
It's
we
not
telling
adding
people
up.
these things?
Yeah. Yeah. It's ridiculous, really. Please explain, because this is something where I get a little bit like lost on the difference between osteoporosis, osteoarthritis, and
Mhm.
osteopenia.
Yeah. I get these people mix up these words unintentionally all the time.
Yes.
And as an orthopedic surgeon, I used to live in the world of osteoarthritis. I'll explain the difference. And now I live in the world of osteoporosis, but they also often overlap. So let me start with arthritis. So osteoarthritis, which is the wear and tear on joints, not of bones, of joints over time. This is the typical like wear and tear type of arthritis, not related to the immune system, not related to some kind of disease. This is wear and tear arthritis, hips, knees, ankles, whatever. Osteoarthritis is specifically of the joints, and that's the arthro part is the joint name in there. Osteoporosis is porosity of the bone. So porosis, porosity of the bone. So this is low bone density by definition, but what we really care about is increased fracture risk. But osteoporosis is the more extreme version, if that's the word you want to use, to osteopenia, which actually was never even a diagnosis. It was a word that was kind of put out there. But really now it's low bone density that then leads to osteoporosis. So really we don't even use the word osteopenia anymore,
Okay.
but it's definitely still out there.
Okay. And is osteoporosis, is it on the rise?
Mhm. Boy, it'd be good to know the answer to that if we screened people appropriately. I think the
Okay.
answer is it is on the rise, but we're not screening effectively and we're not screening early enough. So I think if you were to look at the statistics, probably yes, it's on the rise. But truthfully, we have no idea how bad that rise is because we only screen, the recommendations are to screen for women at 65, men at 70, maybe, if you think there's a risk. And there are some other recommendations to say, oh, if you have risk factors, but most doctors aren't looking at that. And
No.
so we're screening way too late, and we need to be screening for women as they're going through menopause for sure, perimenopause preferably. And we need to really be screening, honestly, all young adults to see what their starting point is. But we're not doing that. So we actually have no idea how many people have osteoporosis.
What's, yeah, I was gonna, that was my question was like, how many people do we think or have this? I always say, like, you get women that will come through your door, and I'm sure you've heard this so many times, which is, I have no symptoms of menopause. I have no symptoms of perimenopause. And I always say, well, can you feel your bones going?
Hmm.
Probably not, because there really
No.
isn't, like, until like my mother-in-law, who had no idea that that was the state of her bones until that happened. There's not a lot of like, does it start hurting?
No. I mean, there are people who say that they can feel their bones, and I won't discount what they're feeling because that might be true. Human body is amazing. But
Yeah.
in general, no, it is asymptomatic. You don't know that you're losing bone, but our bones are telling us a story if we know how to listen to them. And the way that we listen to them is through blood markers and through imaging. So this is why I'm a big advocate for screening. And if you have a problem, we can use bone turnover markers and the bones are literally telling us what's happening with their metabolism. So if you're losing bone based off of imaging, and you can see what's happening with metabolism, we can actually follow this over time and then we can do something about it. But same thing, when I hear women say, I don't have any symptoms as I go through, I didn't have any symptoms as I went through menopause. Well, first off, you probably did. You just didn't know that they were related to that. But even if it's true that you didn't, you can't feel what's happening to your bones unless you're testing and you're looking. You can't feel what's happening in your arteries. You can't feel what's happening in your brain unless you're symptomatic from it, and you may not be. And I'm always supportive of women not using hormones if they choose not to. Totally your choice.
Mhm.
Definitely supportive of that. But at the same time, it needs to be an informed decision. And that's
Yeah.
where it gets challenging.
So, in your clinical experience running and owning an HRT clinic, you were obviously testing everybody that was coming through your door for these markers, which we'll get to what those markers are. What were you seeing in clinic? Like, were you seeing that majority of your patients that you were testing had some degree of bone loss?
Well, for sure. I mean, my world's biased though because people are coming to me because they've seen my YouTube channel or they read my book or whatever, and so they know that I'm the bone guy and they have a bone problem. So yeah, my world, everybody has osteoporosis. If you go to like a more generalized population though, it's not as common for sure, but I think it's more common than we think. And again, if we need to be testing for anybody that has risk factors, and those risk factors include lots of common things. So in my world, it's very common. We see poor bone metabolism, we see osteoporosis, severe osteoporosis, fractures, all the things. But I really think we need to be looking at it in the more general population.
Hmm. I think so too. Because tell us why this is serious. Because I don't think any woman thinks it's a serious thing until it happens to her, until she breaks the bone and then goes, oh my goodness.
Hmm.
And I've heard some very scary stats. I remember hearing Peter Attia say once that, you over the age of whatever it was, 65, if you break a bone, you have a 50% chance of dying within a year. Then I've heard that it was 30% chance of dying within a
Yeah.
year. So what's going, like, why is that killing people?
Yeah. Well, first of all, the numbers are all over the place, but none of them are good. And so there's
No.
quite a bit of variability. And you hear, yeah, 25% of people will die within 12 months after a hip fracture, up to 50, and depending on what population you're talking about. But you kind of laid it out in the beginning too. 1 in 3 or 1 in 4, depending on which country you're talking about, of women will have a fragility fracture in their life. Same thing around 1 in 4 men. I said that backwards. Actually, it's 1 in 2 women to 1 in 3 women will have a fracture, fragility fracture, and it's 1 in 4 men. So it's extremely common, and yet we don't really talk about it that much, and we certainly don't talk about it
No.
until it's much too late. So it's very common, and the morbidity, meaning how bad it is pretty darn high. Hip fractures in particular, that's the high mortality rate of, whatever, 30%, 50%, depending on the population. But what kills people isn't the fracture. And this is where, like, as an orthopedic surgeon, somebody comes in with a hip fracture. It's not like I watch them die in the hospital, usually. What happens is they come in, they've had a hip fracture. They had a hip fracture because they went for so long without understanding what was going on with their bone. They didn't know, or they didn't treat it, or the drugs didn't work for them, and they got very frail. And in that frail state, it's not just frail bones, it's frail metabolic health, it's frail immune system, it's frail everything. And so then you undergo this trauma, this hip fracture, and you end up needing a surgery. Surgery is trauma, anesthesia is trauma to the brain. And so you go through this very traumatic experience in the hospital, multiple day hospital stay, et cetera. And then on the other end of that, most people in that situation are going to end up going to some kind of a care facility because they generally can't go home. So then you're exposed to all kinds of other potential bad things. You're spending more time in bed if you can't weight bear or partial weight bearing. You don't have the upper extremity strength to manage it. And so what we see is it's really the frailty that leads to one of the things that will kill you, which could be a urinary tract infection and pneumonia. These are the normal things that kill people in this type of setting. But it's because you were frail to begin with that led to that thing being able to take over your body. And so it's not really the hip fracture, it's the level of frailty that then results in that, in addition to all the other things.
Yeah, I remember hearing that it was like that you had a very high chance then of getting pneumonia or dying from the pneumonia
That's
that
right.
you could get.
Right.
That's just, but that is very serious. And I just think that people are shocked when they hear that. It's like, oh, what? Like I have that
Yeah.
much of a risk of dying if I get a bone fracture.
Right. And it's not to say all fractures are like that. Like if you fracture your
Yeah.
wrist, it's not the same thing. And spine fractures, while painful and can be debilitating, um, also not quite associated with the same problems. Hip fractures are unique in that way. They are just a very bad injury because of what happens in the months following. But the thing is, we look at the average age of these fractures and they are older. But if we want to do something about it, we don't want to wait until we have that fracture. I see lots of desperate women and men who, like I had this fracture And now I want to do all the things to improve my bone. And while we can help them, there is a, a path forward for them. It's a much different path than a woman in her 50s, or a woman in
Right.
her 30s who's having, anovulatory cycles and like, she's she's has an opportunity to never have this problem in the first place. If we could just educate a younger audience, then this problem goes away.
Yeah. Yeah. Exactly. Let's talk about what the hormones, why do they have such an impact on bones? A lot of people think it's just estrogen, bone health, men, testosterone, bone health.
Mhm.
But all of our hormones can impact our bone health. So, can you explain what each of these hormones, like estrogen, progesterone, and it's estradiol and estrone, but I don't think estriol, or does estriol have bone?
Correct. Yeah. Well,
Okay,
let
yeah,
me run down the list, and I'll
yeah.
actually break down the estrogens. So let's start with estrogen. It is the most commonly talked about, actually, for both men and women, although people might not think they're talking about it for men. But it is actually an FDA approved drug for osteoporosis prevention, not treatment, but prevention. Which is ironic then that we don't actually measure for osteoporosis until women are 65, because then it's, quote unquote, too old. But anyway, so estradiol is the most powerful estrogen for bones. It works on both sides of the osteoporosis, metabolic bone health equation, meaning there's always breakdown, there's always buildup happening in bone. And if we can just shift that ratio of buildup to breakdown, then we're going to see improvement in bone metabolism. And that's how you reverse osteoporosis, by focusing on that shift. Estrogen, specifically estradiol, works on both sides. It slows down bone loss and it pushes on bone building. That's why it's so powerful.
Mm.
Um, Lots and lots of studies on estradiol and bone metabolism and fracture risk reduction and bone mineral density, and it's a very powerful tool. I would put it, next to any of the bone health drugs out there, and it is comparable, except that you can use it indefinitely, which is different than the other drugs. That's why, from my perspective, it is the most powerful tool for bone health out there.
Wow.
Um, but of course, nothing comes for free. There's always risks that you have to talk about.
Yeah.
It's interesting you mentioned estrone and estriol. I've never seen a study specifically with estrone, to be honest. Um,
Oh,
so, because you could argue like, well, doesn't, how much estrone is in Premarin, conjugated equine estrogen. And so I don't actually know the answer to that, but we think that probably the little bit of estradiol that's in Premarin is what saw the benefit in the WHI. I've not seen estrone studied outside of that, or at least I haven't looked for it.
well,
Estriol, though,
does it'll be converted? I just saw this somewhere. Now I'm going to forget what it is, but it was a good percentage of the estradiol that is swallowed from the Premarin is going to be converted to estrone in
yeah.
the liver. So what you're getting in the end is an estrone.
Yeah, it'd be interesting. I guess we don't need to study it because we know that estradiol is what we want, and
Yeah,
and I think
yeah.
everybody's getting away from that anyway, right? But estriol is interesting, and I'm glad you brought it up because there are a lot of women who are on a biest or triest or whatever est cream that has potentially a lot of estriol in it. Estriol is not going to have the impact on bone that we want. In fact, there was
Okay.
one study that I looked at, one paper that had it was three different doses of estradiol as different arms of this RCT. And then as a control, they used estriol. And I remember very clearly when I read this for the first
Ooh.
time, I was like, well, that's weird. Like, why wouldn't they just use a placebo, like an actual placebo? And they said, oh, we chose estriol because we know that it doesn't have any impact on bone. And I was like, wow, that's powerful.
Oh, that
And
is.
indeed, if you looked at that, the control group on estriol, they lost bone over the course of that study. I forget if it was 12 or 24 months. But yeah, it doesn't have the impact on bone that we want. So then for women that are on a bias, especially an 80-20 bias that's mostly estriol, they're probably not seeing the benefit on the bone health that they want to. And that's why we have to test. But that's the three estrogens. Progesterone, logical next one to talk about. Progesterone, usually paired with estrogen. It's not been studied alone that I'm aware of in an RCT for bone health. I would love to see that study because I think it would be a compelling hormone to use off label,
Mhm.
independently for women that choose not to use estrogen because progesterone has so many other potential benefits too. We know that osteoblasts, the cells that build bone, have receptors for progesterone. We know that women who don't have an adequate luteal phase or luteal rise of progesterone will lose bone, even if they're premenopausal. So we know that progesterone has an impact on bone. I just don't know
Just
to
know
what extent
exactly.
and what is, what does the dose mean? And, like we don't know what the exposure means. So I can't say that progesterone by itself is going to have a significant impact on bone. I think it would, but I don't
Yeah.
know. Yeah.
Yeah.
So
I
interesting.
remember reading that there was impact on it. It wasn't huge like estrogens, but that it was important. And we're going to talk a little bit later about the papers on cycling progesterone and what you saw there as well, which was so
Yeah.
interesting to me.
Right.
But so, and then also, do you know much about, there was a study done on the metabolites, on estrone metabolites, 16 hydroxylation, and it
Hmm.
showed that premenopausal women, they didn't want to see high levels of that metabolite because it could cause some damage, like
Hmm.
DNA damage. But then what they saw was in menopausal women that they actually, it could have benefit, and they wanted to see that they did have some of those metabolites because of its impact on bone proliferation.
Yeah. I've seen that.
Yeah.
I don't know what to do with it clinically,
Yeah. Yeah.
but yeah, but I have seen it and you see it, if you use Dutch, you see they
Yes.
talk in the 16 hydroxy pathway. They like, oh, it's beneficial for bone. Like you want some, but not too much.
Yep,
Like, wait,
yep.
wait,
That's what I
how
always
much do I
say.
want? I don't know.
Right. I know. I know. All three of the metabolites in that first pass is, it's like, well, our body is creating these for a reason.
Yeah.
So there's going to be good to them. And then, but it's like always, obviously, it's the whole Goldilocks thing where it's like you don't want too much, you don't want too little, but there is toxic, like you don't want the 4-hydroxylation to be too high
Right.
because this is going to
Right.
cause more DNA damage. But there is not enough information about
No,
this.
no, not at
No,
all. And
no.
that's where I try to just get women access to estradiol, honestly. Like, let's talk about the risks and benefits. Is this right for you? And if so, let's get it optimized. And just I try to keep it simple
So do
because
you use bias very often in your clinic?
never
Never.
anymore. I was trained
Yeah,
on it.
same.
That's how they train. Well, they did then at A4M. That was sort of like the pathway.
Yeah. It's in
Um,
most, I would say 99% of
yeah,
the hormone training that goes on out there,
yeah,
except if you're a medical doctor and you're just getting what you got from medical school, which is almost nothing. They don't talk about estriol, and it's like use
no.
the estradot,
Well,
estrogel,
or
anything
yeah, I mean that ACOG
pharmaceutical.
and the Menopause Society very much whatever FDA approved products. But if you're in the
Yeah.
compounding world, it's usually biased, which it's a long conversation I could keep talking about. But now we really are using estradiol. We're using FDA approved products with our new company at LifeMD. So we have different pathways. We still have
Mhm.
compounding pathways, but our primary goal now is again, it's access, it's optimization, it's lab based. Like let's get whatever you want it to be. If it could be a patch or a gel or a cream, whatever works for you. I just want to get
Yep.
it in your body.
Yep. Yep. Okay. So testosterone, what's
Yeah.
that doing to the bones?
Anabolic. So you think about testosterone, you think, young, muscular guys, right? But women have testosterone, or at least they're supposed to. Women have testosterone, men have testosterone, and you've probably mentioned this fun fact on your podcast before, but women have more testosterone if you adjust for units. Use the same units. Women have more testosterone than estrogen at any point in their cycle.
Actually, that's not true.
Tell me why it's not true, because it looks true to me.
Did you look it up?
I did.
I
I
did
measured it.
too. So many different times. And
Yeah.
because I used to say that, I heard that from everybody. I used to, oh, testosterone is our most abundant hormone. And then I actually did the conversions, went through the whole cycle, and it is not our most abundant hormone. Progesterone is. If you look at how much we actually produce, estradiol is the strongest and has the most impact.
Yeah.
And we have the highest levels in most of the cycle, except when you compare it to the luteal phase when progesterone goes sky high, and it's
Right.
way more than estrogen or testosterone.
Right.
But in
Yeah.
most
Well,
women,
I'm gonna
testosterone doesn't outdo estrogen.
I'm
And
gonna
I've
push
been
back on
like,
that. So
I've
I'm
been
gonna say it's a
asking
unit
people, I'm
conversion
like, give
issue.
me the research, show it to me because I cannot find it. I've
Yeah.
spoken to other practitioners who've said the same thing. I was just talking to Christine Farrell about it. She's a nurse
Hmm.
practitioner, and she's like, same. She's like, I haven't been able to find anything to prove that. I'm like, I'm open to it. I
And
want
are
to
you
see
sure
the
you're looking
evidence.
at the right units? That's my question.
Yes,
Comparing
100%.
different
And then I
units.
even took the units and I converted them myself and I looked at different papers and had them convert it for me in Perplexity and ChatGPT. And so, because I thought, okay, well, maybe I'm doing the math wrong, and it's like, and even when you research it, that everything you'll pull up will say that it is not, that estrogen is our most abundant hormone, it says. Even though progesterone does outweigh it in total, but only through a part of the cycle.
Yeah.
Yep. No. Hey,
Um,
bring it on. But yes,
well,
I'm trying.
all right.
I'm trying
I'll
to
prove you wrong.
find
We'll
that
do part
out.
two.
Yeah. Yeah. Okay.
Um, all right. But anyway, so even if it isn't, it is still
Yes.
important.
Yes.
And
Very much so.
so testosterone, though, not studied well in women. So there are studies on testosterone in men and with bone health. There's two studies on testosterone in women and bone health that I know of. In men, we see that testosterone will increase bone density, but they don't use enough testosterone and they don't raise levels very much with they use like a whiff of androgel and they don't raise their serum levels very high. But bone density still goes up, but they've not done the studies large enough or long enough to see a reduction in fracture risk. So that's all we can say about testosterone in men. It makes sense physiologically at the cellular level. Osteoblasts respond to it. It should help us to build bone. We know it helps us to build muscle. But we just haven't done the right studies to really say by how much and at what dose. For women, there's really only two studies. So there's one RCT that looks at testosterone in conjunction, I think it was a testosterone and estradiol in a pellet, and then with oral micronized progesterone compared to estradiol in a pellet versus oral micronized progesterone alone. And when you added the testosterone, the bone mineral density results were better. So maybe, right? Small trial, not really the way that I would do it, but it showed signal. And then there was recently, just this year, published a retrospective study looking at older individuals, older women who were on testosterone, and they did have a reduced fracture risk compared to those that were not. Probably some selection bias in there, but still, there's signal, right? So it's probably beneficial for bone in both men and women, but not enough research to say by how much.
Okay. In just a little, I was just thinking about this when you were talking. In men, we don't treat men in our clinic, but you do, correct?
Yep.
You do TRT. So for men that are on anastrozole, and for those that don't know what that is, it's a estrogen blocker prescription that a lot of men will be automatically put on when they start testosterone replacement therapy to block the conversion of testosterone to estradiol. Do you see that that could impact bone health in men?
Absolutely.
Okay.
Absolutely.
Do
Yeah.
you
So
not
I was
use it?
No, I don't use it at all.
Yeah.
So I was trained I was trained for TRT, same thing, right? So we use, testosterone cypionate, 200 milligram per ml, twice a week injections, anastrozole, and you could, some people use a lower dose, use it less frequently, whatever, but still in the blood in the lab results, most docs are looking for estradiol to be suppressed, like less than 20 or unmeasurable. Problem with that is when we look
That's
at
not good.
testosterone, the benefits for bone, yeah, it is a little bit anabolic, but it's thought that really the benefit for bone is the conversion of testosterone to estradiol in the body that then acts like estradiol in the body for women on both sides of the bone metabolism equation. So when you eliminate that, you do actually see men on TRT with very high levels of testosterone, no estradiol, and osteoporosis. So I don't think that the lack of estradiol is going to be outpaced by the potential anabolic of the testosterone alone.
Right.
And this is a concern, and I went away from it very quickly because I sort of, did the math and figured it out. We want men to have estradiol, heart
Yeah.
protective, brain protective, bone protective, just like it is in women and men. And if you're
Yeah.
symptomatic because you have quote unquote too much estradiol, you really need to dig in and see, is it really too much estradiol or do you have too much hormones in general? Right? Because I'll
Yeah.
see guys that have immeasurable, their testosterone so high and they're complaining of breast tenderness.
Yeah.
They don't need anastrozole. They need less testosterone.
Yeah.
Right? Like there's not a single patient I have on TRT that I have on anastrozole that we haven't been able to balance their testosterone without it.
Yeah, yeah. And it's a really diet too, right? Because if they're leaner and they don't have as much body fat, they're not going to convert so much to the estrogen, I've heard.
True. Yeah,
Yeah,
it's true.
yeah.
Yeah.
Have you done much around selective androgen receptor modulators? Because I hear that they have or been studied for bone health, like to help with women that have osteoporosis. Same with anabolic steroids.
Yeah, so I've looked at like nandrolone, for example, as an anabolic
Yeah, yeah.
steroid, and there is research on nandrolone. There was some older studies. They kind of pulled back on it because there was more concern around, the virilization, the masculinization of women with this anabolic steroid. Although I have word from some researchers recently that they're looking at it again and they're not finding these same side effects. I don't know what happened
How
back
could
then.
they not?
Um,
Oof.
I don't know. But I would love to see something other than testosterone, especially something that's not on the controlled substance list that we can
Yes.
use that would have the same impact.
Yeah.
Because we need something like that. We need something anabolic. I haven't looked into the SARMs specifically. Again, commercially, they're not easily available, so I can't
Yeah.
I can't prescribe them. So it doesn't
No.
do me any good.
I was researching it recently, and I just think that I'm like, why are we not using this? It's
Mhm.
selective, and so for those that are listening, they target muscle and bone primarily. So the receptors on muscle and bone, and then they'll leave alone, not completely, but a lot less than testosterone and nandrolone and oxandrolone and all these other anabolic steroids that hit all the androgen receptors. And that includes your skin, your hair. And this is,
Right.
women, when they take testosterone, they'll lose their hair, they get greasy skin and whiskers and like things that we do not want, but we want the testosterone and the benefits of the testosterone. And it can be
Yeah.
so great for arthritis, autoimmune condition, bones, muscle wasting. It's like, come on, why are we not using this, people? So
Right.
hopefully one day. I hear that they're possibly gonna pass one like through the FDA. So we'll see.
Yeah. I'd love to see it.
Yeah, me too. I'm fascinated by all of those things. I've got a girl coming on, Victoria Felker, who's done her whole like PhD thing all around anabolic steroids for women. And it's pretty like we should be using them compared
Mhm.
to other drugs that are being used for these things, including I have heard that stuff for osteoporosis, the medications can be really harsh.
Mhm. Yeah,
Yeah.
there's significant risks, side effects. Yeah, there's a time and a place for these drugs, but I don't like the idea that we're using them as a primary tool because there's not a good long-term plan with them, and
Hmm.
they generally don't work with bone metabolism. They work against it. So, yes, again, time and a place, but I don't love them. Happy to get into the details.
Yes. Well, let's first go back to HRT and bones. Do you like to get a woman? So obviously we need all three hormones. You're a big proponent, all three hormones, good for bones. One of your favorite tools to use, which is great. Do you like to see estrogen at a certain level? Because I have seen some PubMed research that showed in some studies that they didn't see bone protection until estradiol got to a certain level in the body on
Yeah.
HRT.
Yeah, there's a couple studies on this, and so I think I pulled like four different articles that talked about this threshold, this tipping point, somewhere around like 60 picogram per ml for estradiol
Yep.
and serum, and so that's our kind of arbitrary line. So yeah, we use that as an idea, 60 to 80, maybe that's the sweet spot. But what we found clinically, because we're measuring estradiol, FSH, CTX and P1NP, the bone turnover markers. So we're really looking for all of these things to come into alignment. And what we've found is that there are some women who have lower levels of estradiol, 20, 30 picogram per ml, who have an FSH that is under 30, it's suppressed, and CTX and P1NP that look perfect. So for that woman who has no symptoms, who feels great, I'm not compelled to offer her more estradiol, right? Why would I? And then alternatively, there are women who they hit that threshold, 60 to 80, but their FSH is still 100. Their CTX is still really high. We'll explain that in a minute. P1 and P is still really low. And so for that woman, do we not offer her more? And then we ask about
Mhm.
symptoms, but it seems like probably she needs more estradiol. So we use it as it's an arbitrary number that we put out there, but we don't stick with it outside of, the bigger picture. So we don't just go hard line on that. We look at the bigger picture and look at the other biomarkers.
Do you think that that has to do with maybe the woman's lifestyle that's going in conjunction with her hormones? Like maybe she's not lifting weights or,
I don't know what it is. Is it
yeah.
lifestyle? Is it something outside of that? Is it an inflamed, body? Is it, is it a cell, like, is it a receptor problem at the cellular level? Like, I don't know. I'm just looking at clinically, like, are we seeing benefit? And I will say that for women who don't, who we don't see CTX come down, FSH come down, we don't see their imaging get better. So I still am very interested in the bigger picture, and I would love to know why this happens in some women, but it definitely happens. And this is my concern around the idea of not testing. And I know
Hmm.
you're an advocate for testing. I'm an advocate
Yes.
for testing, but I get yelled at by OBGYNs on social media when I talk about testing, and they say that's not how you do it. And I
Oh,
say, well, you don't know
jeez.
if you're actually helping your patients then,
Exactly.
right?
Because there's
Um,
many things that show estrogen needs to get to a certain level for even your brain, I remember there was I feel like it was a mouse study though, but there was after 1 milligram, 2 milligrams of estradiol, HRT showed brain volumization. 1 milligram and no estradiol did not have it.
yeah. And, I mean, and you look at the same. There's human studies on patches and bones, and there's studies at the point the 50 microgram level. There's studies at the I think it's the 37.5 level, but at 50 mics or 0.05 milligram patch,
Yeah.
the study said that women are covered with this dose, that you don't need to use anything more. But when you look at the actual numbers, I forget the exact numbers, but it was barely over half of the studied population that actually saw no loss in bone. I don't think they actually gained bone mineral density, so clearly it wasn't optimized. But there
No.
was, over half of the women didn't lose bone, and they said, "Oh, well, then that's all you need." Well, what about the other
Ah,
half? Right? Like
yeah.
they need more estrogen, and you're just saying like from a population basis that a 0.05 milligram patch is all you need. No, actually, for the rest of them, maybe they need more. And so it's this idea that like, well, we know that 0.05 milligram patch is all we need for women, and that protects bone, and the research supports that. Well, no, if you read the research, it doesn't. And we need to look at everybody's individualized hormone levels to understand what's happening with the doses that they're on.
Would you say that in general, you would want a woman to get her levels above 50 because that is what you see working best?
I mean, I think it's a good, again, it's a good arbitrary line to draw, but
Yes.
I want to
Yeah.
know what's happening with FSH and CTX.
Okay, so let's talk about that. Why FSH?
Yeah, so I learned this in the PR space. So when we start looking at physiologic restoration, what's happening with all of the biomarkers, because now we have estradiol rising and falling, progesterone rising and falling.
So,
We,
sorry.
we'll get there. Yeah.
Physiologic restoration, everybody, is a rhythmic dosing of your hormones, your HRT. And
Hmm.
I've talked about this on many podcasts before, but just so you guys can go look this up. But it's higher dosing, much higher dosing, mimicking your cycle and levels of like a 25-year-old. Okay, sorry. I
Right.
just wanted to
Your
so they
young,
knew
your
what we were
younger
talking
self.
about.
if you
Yeah.
choose if you choose
Yes.
to go that pathway.
Yes.
But when we do that in the PR world, the physiologic restoration world, we look at FSH. Now, I was obviously
Yeah.
not trained on that initially. Most doctors looking at postmenopausal women are not going to use FSH. They really, if they're measuring at all, they're just measuring estradiol. But it makes sense, right? Because we know that for cycling women, we know that FSH will rise and fall, and at the peak of the follicular phase, FSH is going to be very suppressed, right? So this is a sign that at the cellular level, your cells have all the estradiol that they want. So then in this world, we say, well, if your FSH is suppressed down below, whatever percentile 30 is, but 30, 20, 10, different docs use different numbers. We use 30, but if we can suppress FSH down to that level, then we have a good sense that estradiol is doing what we want it to at the cellular level. There's actually some additional studies recently that have been looking at FSH independent of estradiol, saying that FSH actually has an independent mechanism on bone. It's the same
Oh,
reciprocally to estradiol, but FSH might be more important than we think. So definitely measuring FSH, and I want it to come down,
interesting because it's a brain hormone.
right?
Yeah,
Yeah,
very
it's your brain
interesting.
telling your ovaries to make more estrogen, right? It's the
Yeah.
feedback loop. And
Yeah.
so if we can measure that other side of the feedback loop and it's still high, then that tells us that your cells are still screaming for, your cells are screaming for it. Your brain's responding to that scream. Your brain is screaming at your ovaries to make more estradiol.
Yeah.
So it would make sense then, if that's true, that you don't have enough estradiol.
Yeah. Yeah. And there's a little bit of evidence now too that they're doing around weight gain in menopausal women compared to where their FSH is. And they see, and there
Interesting.
was one study showed that after 23, FSH gets to 23 or above is when they see the weight gain happening in menopause. And so that would just
Interesting.
be like a
Yeah.
marker again of your body is now crossing that threshold of there's really not enough estrogen here for metabolic health.
Right. Yeah.
Yeah.
So it's the feedback loop. Yeah, it's interesting from a weight management perspective. I'd like to look at
Yeah.
that.
Yeah. So physiologic restoration, they cycle their progesterone. And this is where a lot of the controversy happens around do we cycle hormones or do we not cycle hormones? Physiologic restoration has been around for a long time. It started out as the Wiley protocol. Uh, like I said, it's high dosing. And she was a Wiley, T.S. Wiley was the one that developed this. And she was a firm believer that we needed to follow the cyclical pattern that we do in a 28-day cycle to gain the most benefit out of our HRT in menopausal years. And there's a lot of people and a lot of doctors that'll be like, no, they just need static dosing. Take your progesterone, estrogen every single day. All is well. I've done a whole podcast around this. But we see that there's obviously not enough research, but we see that could be benefits if you understood why we go up and down with these hormones in a 28-day cycle. You could see why we would maybe want to cycle our hormones.
Yeah.
And I heard you, Doug, which is why I asked you to come on the show. I was like, oh my gosh, Doug's talking about cycling progesterone. And you found some interesting papers that
Yeah.
support that maybe cycling progesterone could be better for bones.
Yeah. It's interesting. And so
Yeah.
I got a lot of pushback when I started talking about it openly, again,
Oh,
mostly
it's so tough.
OBGYNs, who were really actually calling me out by name pretty aggressively. And so the reason why I started doing that is because I created, when I was especially, doing research for the book and creating these talks that I'm doing around the country on hormone optimization and bone health, I looked at as many studies on hormones as I could, hormones and bone health. And what's interesting is there's actually a body of research that hormone doctors, OBGYNs, aren't going to be exposed to because they're in the orthopedic literature. And so, like, unless they're reading, the Journal of the American, whatever, like all of our societies, unless they're reading those journals, they're probably not going to see them. And what was happening especially in like the 90s, a pre-WHI era. So what was happening in the 90s is that people were doing what I think is the right kind of research, which is what is the right dose? What's the right route? What's the right, like what's the right rhythm? Like what are the different variables that we can pull to see the impact that we want to see? And these researchers were looking at bone. And so back then in the 80s and 90s, some kind of a rhythmic approach was actually more common than static. It was actually the standard of care, even
Wow.
before T.S. Wiley and PR. And if you think about it, that makes sense because your estrogen and progesterone were cycling back and forth every 28 days on average for women. So this is one of those rare circumstances where we take a hormone that used to go up and down on a regular basis and then just give you the same dose every day and expect to have some kind of a similar result. Like it's kind of illogical.
Yeah.
And so early protocols then used some kind of cycling. And that could be a static estradiol dose with progesterone only half of the month, or 10 days of the month, or 3 weeks of the month. And the numbers were all over the place. But most protocols were some kind of a cycle. Some people would even use, higher levels of estradiol in the first 2 weeks and lower levels to kind of mimic follicular and luteal. So some really interesting protocols out there. And when I looked at that and compared what was happening with the bone mineral density outcomes or whatever they were measuring regarding bones, the outcomes were consistently better in cycled protocols than they were in static protocols, because those static protocols existed too. Now, when I got criticized around this, the criticism was, well, what about the other variables? And it is true that in some of those studies, they also used more estradiol. So is this from the cycling progesterone? Is this from the higher levels of estradiol? We don't know. But I can say that it was consistent that every single cycled study protocol did better than the static study protocols. So that's what got me interested in it. And so now clinically what we do with this is for women that are not seeing improvements on a static protocol, or maybe they were seeing improvements and now they're not, then we consider saying, well, what about cycling? Because I don't think it's dangerous. I don't think we're exposing them to more risk. PR is kind of an interesting conversation of what happens over time with that. But at least cycling progesterone, I mean, it is still, I mean, there are some databases, if you look up, like, how do you do HRT? They talk about cycled progesterone as the standard of care. It's not what most doctors are doing, but it's
No.
definitely not wrong. And if you do that, can you push a little bit more on those osteoblasts? And I think the answer is probably yes. We do see improvements in numbers when we do that. But the downside is if you're on a cycled protocol that's done right, you're probably going to menstruate if you have a uterus. And
Mhm.
so this is where, like, I hear people say, like, should I be spotting if I'm cycling? And the answer is no, you should actually be bleeding if you're cycling, because if you're not actually bleeding on a monthly basis, then you probably don't have enough estrogen. And so then it gets into the question of, well, do you as a postmenopausal woman want to continue to have a cycle? And that is totally up to you. But I do think it's an interesting tool.
Yeah, and I always say it's not the same as when you had your cycle as a cycling woman. Like
Mhm.
I cycle mine, I get a period. I don't get the breast tenderness. I don't get the emotional instability as much. Like all of the PMS has really subsided. And you'll hear that from women that do cycle their hormones. They'll say that. They'll be like, oh, it's nothing like it used to be. Like
Right.
you have a light period for a couple of days, without all the emotional garbage on top of it, everything's good. And they prefer to cycle for that reason. And they're like, yeah, it's not what you think it's going to be. And I agree with that. And that's what we've seen. But
Mhm.
would you, did you see in these studies that it was like the 1 week break compared to a 2 week break from progesterone? Was there a difference? Did you see that?
Not
I
between,
always
there's just
get
not
that
enough. Like,
question.
yeah. I mean, what makes sense to me is to follow, like, 2 weeks and 2 weeks, right? Like
Yeah.
follicular luteal. So that's what we do if we're going to do it. Generally, we'll do a 2 week cycle of progesterone.
Yeah, same.
Yeah.
But some women, they're just so dependent on it that I'm like, okay, if all you can do is 1 week off, then do the 1 week off, And they're like, okay.
Yeah.
But
Well,
usually if you
or
get your estrogen high enough,
right. You may not need it, or you can do 100 milligrams for the first 2 weeks and then increase it and then withdraw it. And that
right.
works too. And then you still have some coverage for the sleep benefit.
And so I've heard you talk about how it's the push pull of estrogen that could be the benefit to the bones, like what it's doing when you're pushing and pulling without those hormones that could
Yeah.
help the bone.
Yeah. Yeah. So, and it comes down to the receptors. And again, this comes from the PR space, but essentially when estrogen is dominant, right? So the first 2 weeks when you have very little, if any, progesterone, during that time, the hormone is interacting with the cells all over the body and interacting with the estrogen receptors. While it's doing that, it is getting the progesterone receptors ready. So the progesterone receptors have gone away, estrogen is dominant, and then the progesterone receptors are going to come back out. So estrogen provokes the progesterone receptors. And then in the luteal phase, as progesterone rises, it's interacting with the progesterone receptors, and then that same thing occurs. The estrogen receptors have kind of fallen back, although there's still some estrogen, actually not an insignificant amount of estrogen in the luteal phase, but there's less receptors. And so then as progesterone rises and falls, that same thing happens where the progesterone receptors start to pull back and then the estrogen receptors start to come forward. And it's that push pull of the two that has the impact that we see physiologically with the hormones. And definitely with bone, because we know, because we measure bone turnover markers, that if you are measuring, during the follicular phase, you're going to see very low CTX. That's the breakdown marker. Measure during the luteal phase when estrogen's lower, and it's going to be much higher. So we know that bone metabolism is shifting back and forth during that 28-day cycle.
Yeah, and there was a good 2017 meta-analysis that you talk about where they looked at, a whole bunch of different studies that were done on that looked at static versus cyclical HRT. And it was pretty astounding. Like the European arm of the branch, and one of the study or multiple studies, I
Yeah.
think Europeans, I guess, cycle their hormones typically
More than we do, for
more
sure.
than we do. Yeah.
Yeah.
And compared to static and no, I think no HRT was the other one.
Hmm.
Europeans had 2.5 time increase in bone mineral density compared to
Yeah.
the other arms of the
Yeah.
study.
It was substantially higher. Yeah.
Yes. Yeah. So in your world, if you could decide for every woman, would you be cycling the progesterone, Doug?
Boy, that's a loaded question.
People always want
Uh,
to hear that though. They want to be like, what would you do?
well, yeah. So I never decide for any woman.
No. But
But
you can say
I
what
but
you
I
feel is
educate around
best.
it, right?
Yes.
And so
Yes.
I will say that honestly, we generally will start with static dosing, which might be boring, but it is what most women are expecting. It is easier, it's less symptomatic, and for a lot of women, it works. So we don't start cycling. Again, we use it as a tool in the toolbox. Same with PR. It's a tool in the toolbox. And we're using PR, less and less just because it's hard for everyone, right? It's hard for women, it's hard for the provider. It's more side effects, more back and forth, dosing adjustments, et cetera. Is it worth it? And the truth is we don't have the research to say that it is.
Yeah. Yeah. I always say that to women. I'm like, look, there's millions of women out there that are not cycling. There are more women that are not cycling than cycling. So, because
Yeah,
people will freak out, they'll hear me talking about it. He'll Director Gersh talk about it. You talk about it, and they're like, should I be cycling my hormones? Oh my gosh, and it's like,
right,
if you feel that that is something you would like to experiment with, great, let's do it.
right.
But are women suffering by doing static? No.
No,
Some women, they need to. Some women need to even go to the physiologic restoration levels to get the most out of their hormone therapy. Everybody's different.
yeah.
So, quick fire questions, because I know you only got a couple minutes here. What are the tests that we are asking our doctors to do for us to test our bones?
Okay.
CTX.
CTX, which stands for C telepeptide, and
Hmm,
that's the breakdown marker. And then P1NP. And I can never remember what this stands for, but just look up P1NP. You'll find it.
okay.
It's pro collagen type 1 something in terminal pro collagen something.
Okay. I didn't know there was like really specific blood tests that we could get done. So that's good.
Yeah, it's cool. And then let me explain this quickly too. So the absolute numbers are relevant, but because there's two of them, we need to know what's happening as a ratio. So this is
Okay.
research supported. I get feedback on this too. But if you do a ratio that adjusted for units, like testosterone, but adjusted for units, P1 and P over CTX. And what that looks like is usually a 2-digit number over a 0.3-digit number. The CTX usually is a 3-digit number, and so you just have to move the decimal point over 3 places. So again, 2-digit number over a 0.3-digit number, and that'll give you something between 150 and 300 usually. And with that ratio, higher is better.
Okay. Oh,
Did I
I'm going
lose
to
you
do
there?
this. Well, you totally did. But I'm going to just have to re-listen or I'm going to look it up and write it down.
Great.
I'm sure. Do you have this stuff on your website somewhere?
So in our community, the Osteo Collective, we
Hmm.
have we walk people through this all day long, every day. Yeah,
Okay. Is there a way to reverse bone degeneration?
absolutely. Change the
Okay.
metabolism of bone, increase the building, reduce the breakdown.
So through multiple different means,
Yeah.
hormones,
Lots
amino
and
acids.
lots of levers, but yes,
Yeah.
it is
Yeah.
absolutely possible if you have the capacity to do those things, to do those levers.
Okay. And what besides hormones are your top things that you want to see somebody doing?
The great thing is, it's the lifestyle pieces.
Yeah.
Eating a protein forward, adequate nutrient diet, doing resistance training as your primary form of exercise, not being sedentary, getting adequate sleep, having the right mindset. Those four things plus hormones, you should be good to go.
Golden. Golden. The golden ticket to healthy bones.
That's right.
If somebody doesn't want to take hormones, is there your top three supplements? Do you have supplements for this that you would say these are my top choices for
Yeah,
if you have
there's
osteoporosis?
hundreds of supplements for bone health. And the challenge is what's right for you.
Okay.
And so this
So
is
it's
where I'd say
individual.
like I like using biomarker driven supplement recommendations. This is where getting people into the community where we have like you can get access if you're if you're in the US, you can get access to the labs and you can, we have a kind of step-by-step approach, like if this, then this, based off of the lab results. So we can help you get there, but we need a little bit more information.
Okay. I'm going to actually create a lab test kit that has these markers on it in my shop, you guys. So I'm going to link to that in the show notes. So if you want to order your own labs on these, you can. Um, okay, Doug, I know you have to go, and I have many more questions for you. You're just going to have to come back, I guess.
All right. We'll
Part
do
two.
episode number 2. Yeah. But you're right. I got to go. Thank you so
Okay.
much for your time, Karen. Appreciate
Thank you
it.
for coming on the show, Doug. We'll
Yeah.
talk to you soon.
Okay. Bye.